everybody. Welcome to our April Talks on Tuesday. This is the first part in a two-part series on early intervention and feeding, when to seek a specialist. I am delighted to welcome Kim Geisinger, who is an occupational therapist, who will do a little bit more to introduce herself. But Kim, I just want to thank you for sharing your expertise with us. So I'll turn it over to you.
Okay, thank you. Welcome everyone to today's Talk on Tuesday. I hope this webinar finds everybody healthy, your family healthy, your coworkers healthy. Today, like Corey said, is part one of our two-part series, and I'll be giving you the actual feeding piece today. And Stephanie Shrewsbury and Jessica Hale will continue next month with information strategies from a service coordinator and developmental specialist perspective. As you heard, this is interactive, so we can all share experiences and ideas, and I encourage you to participate if you can, because it's always good to get everybody else's perspectives. So I want to tell you up front and let you know that this is not a webinar about being a feeding specialist, and I'm not going to give you any advanced tips or strategies on medical feeding therapy or coaching families through transition from nasogastric or gastrostomy tube feedings to oral feed them. That's not really what my aim is today. My aim today is to give service coordinators, developmental specialists, and other primary providers working with families who have expressed difficulties or challenges with their infant or their toddler on intake or during the team assessment, or maybe sometimes even weeks or after you've been seeing a child for another reason. I want you to understand what is typical feeding for a child at different age levels, and if you know what's expected, it'll be easier for you to decide if the team or you yourself can help coach a family through some feeding issues. But conversely, if you know what's atypical feeding, you may feel better recommending further assessment when you are doing a team assessment. So some parts of our state don't even have feeding specialists, which is why Corey asked me to do this webinar for you, because in some parts of the state, there's not even medical specialists close by. So families rely on the early intervention providers that come to their home to tell them what to do or where to go next. So I put up this early intervention slide because I'll tell you a little quick bit about myself. I've been an OT for 32 years. I started my OT career right out of Quinnipiac University in Connecticut, and I went straight to Yale New Haven Hospital, into their NICU, into the pediatric floors. And then we moved to Virginia, and I started working at Children's Hospital of the King's Daughters in Norfolk. But in 1993, Tracy Miller talked me into coming to Rehab Associates. So I switched my career to early intervention while I still simultaneously continued my clinical rehab specialist job at the Southside Centera NICUs. So in the morning, currently I see babies at home through early intervention, and then in the afternoon I go straight to Centera Princess Anne Hospital where I see premature and sick babies. And so I have to continually remind myself when I get to a family's home that it's not my responsibility in families' homes to medically treat the individual child like I do at the hospital, but coach the family through various routines and learning opportunities to reach their IFSP outcomes. So there is a handout, like Corey said, that accompanies this webinar. I hope you are able to download it or print it, because I'll refer back to it often. And so if you have it available, that would be perfect. If not, don't worry about it. You can print it and take a look at it later. And in that handout, I offered helpful takeaway tips and some strategies that I used in the patient videos. So my webinar today has patient videos in it, which have been shared by the parents and given parent permission. So you ready? Let's get started. So when you're thinking about feeding, I want you to think of the bigger picture first, the big picture. Then we can narrow our scope down to children at certain ages. So to understand feeding, you have to start with gathering information about the family's mealtime routines. So take a look at this family. In the chat box, I want you to share ideas. And so type 2 to 3 words that describe what you see of this family. If you were sitting here looking at this family, what would you think? I'll give you about 30 seconds. Yep, eating together. Mm-hmm. They're all sitting there together. Yep, they're all eating. Yeah, perfection, exactly. Yep, very inclusive. Yeah, everybody looks like they're enjoying it, right? Yep, they're showing the children what eating will look like. It's a positive experience. The little boy doesn't look like he knows or wants that little utensil, but he's dealing with it. Mm-hmm. Yeah, very good. Thank you, everybody. So that was great. So the first thing I see about this family, and I think normal. Doesn't this family look normal to you? So as you can see from everybody's responses in the chat box, that it looks like many different things to different people. The parents are eating a healthy meal, which you guys said. They're drinking water, right? The little boy has the utensils, like I said. The little girl's drinking from an open cup. It's perfect, right? So you would probably not see this family. But if you did, hopefully it would be on the day of discharge. That would be the greatest. But in the back of your head, I want you to remember that when a family tells you during the intake or on the assessment that I want my child to be a better eater or to be part of the mealtime ritual, this happy, healthy thing is what they have in the back of their head. But I always say it can be healthy, but it can be interactive, it can be happy, positive learning opportunities, practicing new skills through this one everyday activity. But this is too perfect, right? So continue to ask more questions. Does it look like this only on Sunday after church? Usually the answer would be yes. So continue to push the family. So how about lunchtime during the week when dad's at work? What does it look like? Or weekday dinners when mom works second shift and dad's alone with the kids? What does it look like? Ask further questions, which will allow parents to give you their various everyday routines, not just one. So here you go. Can mealtime look like this? This is my patient Mara, that her family, her mom's taking the picture, but they usually eat lunch on the couch in front of the TV. So as you can see, mom has this piece of fabric that she has on the couch so that if it's messy, it's okay. She just cleans it up. But remember that this can be a normal routine and a normal place to eat for some families, because some families don't even have high chairs, and they don't some don't even have a kitchen table. So as long as it's still happy, healthy, and interactive, that's their normal. So as you can see, Mara's telling him all about her morning, and he's just listening and smiling. And those are in-depth questions that I hope were obtained on intake, if possible, by the service coordinator. So that way you have this information about meal times when you walk into the team assessment. It will make service planning so much easier if you have this information already written down for you. Next month, that's Stephanie, who's our service coordinator. We'll dive deeper with you into questions and conversations that get to the heart of the family's routine and then the child's specific feeding issues. So let's share a little bit. What kind of questions do you ask about feeding? Give us a brief question. I'll give you 30 seconds. Maybe there was something I missed. So what would you say? What would you ask them? How often? What does a typical family meal look like? Mm-hmm. That's right. Not all families eat 3 meals a day. Yeah. Typical family foods and where do they eat? Where is very interesting. I've gone to a lot of different places in the home where families eat. You would be really surprised. Do they show preference of certain textures? This is still global though. You're still trying to think about what the family's routines are. Don't narrow your scope yet. You will though. What does it look like? Good, good. Okay, great. So now let's look at all the outlet. Now you know about family routines, okay? So now let's take a few minutes to get a little bit narrower and talk specifically about a child's feeding issues. So when you say feeding, is it about filling a bowl full of food and putting it in front of the child to see what happens? How many times have you seen, look at this little emu, this is my son Mason at the zoo, but when I saw this emu, I cracked up, because haven't you seen this same face on a child at the table, the face that says, no matter what you do, I am not gonna eat that. I have seen that face 100 times. So there are typical and atypical behaviors, reflexes, nutritional requirements, sensory and motor skills. There's growth curves that parents need to help their child meet. There's family dynamic issues, cultural differences, and of course the mom guilt or anxiety about her child's eating. There's so much more clumped together into that one word that we call feeding. So today my goal is to help you learn what you can do before deciding you need a feeding specialist. Okay? So now let's start looking at a child's abilities and skills. So you were asking me, you were telling us in the chat box, some of you, about picky eaters and asking questions that get to the heart of a child's feeding issues. But let's start way at the beginning, because to me, I feel like I have to understand a child's basic life requirements, because they are tantamount to assessing and then coaching a family through their child's feeding issues. So I want you to think hypothetically for a moment. During a team assessment, a mom expresses a fear that her child, her baby, is having feeding issues, and the doctor is concerned that he's not gaining weight. Where do you start with your questions at the assessment? So answer this poll for me. This is a poll, and Jeannie will show us the poll. Is a body's first priority feeding? Is it a myth or a fact that a body's first priority is feeding? Jeannie, you want to show us the poll? Thank you, everybody, for chatting. Good. There you go. Good, everybody. Thank you. Good. So we have 86% it's a myth and 14% that it's a fact. Thank you, Jeannie. Okay, so let me exit here, click back on here. It's a myth. So very good. Breathing is the body's first and foremost priority. If a baby can't breathe adequately or efficiently, their suck, swallow, breathe coordination is impaired. This may lead to increased work of breathing, decreased endurance or stamina to breast or bottle feed, then needless energy expenditure, and thus weight loss. Sometimes just watching the baby eat can give you this information. Postural control or correct body alignment, either by the body itself or through adaptive positioning, is the second body priority. Feeding is actually the third body priority. If any of you have breastfed or bottle fed a baby, you'll remember it's most important to keep their airway open so that they are breathing comfortably during the feed. Then we cradle the baby in midline alignment to successfully take in the milk without coughing or choking, not with their neck hyperextended or flexed forward or turned to one side. So what is typical? So here is where your handout comes in, because I've given you some ideas on what is typical for an infant birth to 6 months. I'd love for you to add any further experiences you have. So quickly share with us a few words about typical feeding for infants, something you've seen, and I'll give you about 30 seconds. That's different from what I gave you on the handout. Thank you, Beatrice. I'm biased too. Anything else that I missed? Typical? So when you walk into a house and mom tells you this is happening and this is happening, you can say, well, guess what? Those things are typical. A happy spitter is what I always think of in this group, because every mom you walk into the house, they say, my baby throws up. And so we say, okay, does your baby throw up? When your baby throws up, does the milk just come out and he just goes on smiling and happy? Or does the milk come out and he's crying, pulling up his legs and bunching up his, pulling his knees to his chest and crying? So if they're happy, then that's just a happy spitter and it's typical and it's okay. On demand, yeah, very good. Playing with food, great. Anything else I missed? All right, so in this slide, on this slide, I showed you a child with a cleft lip repair, and this is just a little FYI for you that most infants get their cleft lip repaired in the first 6 months of life. And feeding can be painful afterwards, the first 1 to 3 days after the repair. There's some bleeding and there's some oozing for several days, and it's painful. But if a parent is aware of this up front, they usually are not as anxious or worried about it when it happens because they expect it and they understand it's okay. The baby's response is normal and it's not their fault. So if you gave them that information, they're usually okay about it, and you don't get a call and saying that my baby just had a cleft lip repair and now he's crying when he eats, because the mom has already been told that that is typical. Now that you're aware of what's typical, what's atypical for this group? So I gave you some atypical issues on your handout, so you can take a look at them. But there are some things that are typically, well, or I call atypically typical. So some of those are certain groups of infants. And this, because I am still the NICU OT, I'm still privileged to see premature and sick babies and their families from the day they're born until the day they're discharged from the hospital. So I have a little video for you to look at a typically atypical feeding.
All right, so Mom, before we start to give him a bottle, what's the first thing we need to make sure that you have going?
That the position is correct. Oh, breathing is
Correct, you got it.
first priority.
So tell all my friends how you're going to evaluate that.
Paying attention to clues such as feeling his back.
Yeah.
Give it to us.
So take 5 to 10 seconds to let me know that you feel like he is breathing adequately before you start.
He was taking breaths.
Yep, good. Holding his breath.
Giving us a show. I can feel him breathing on his back. Hey, buddy.
Okay, good.
And I can hear him breathing.
And he's mad.
Yes, he's mad. He's
All right.
hungry. Okay.
So at least we know he's breathing. That's good. So Suzanne, do you mind taking a picture of his, of his monitor? All right, so he's breathing properly. So what's the next thing we should look at before we feed him?
Then we need to make sure this position is correct.
Perfect. Go ahead. Do whatever's been working.
Okay. Don't get too fast.
Bib.
Hey, bud. Here, we'll take your hat off. Make you nice and cool. Okay.
Where's the bottle?
Okay.
So you're going to make sure his head and his
Head and
body
his neck and his body are all in line.
arm forward. Perfect.
This is I'm ready.
Bib. There you go. Sorry, buddy. All right.
You ready?
So Mom's using a left side lying technique a little bit so that the milk is dropping off actually into his cheek instead of straight over his throat. So how many times do you think you have to pace him?
Hang on. Like how many times in the whole feed?
Yeah, no, are you counting
in general?
anymore?
Sometimes, just generally, as I watch him, he's gotten better in terms of breathing on his own, pacing himself.
Okay, perfect.
So at most we go, yes, so there.
Okay, good. So there's his pull away, so he knew he was, he needed to take a breath. Good job, Jack.
Okay, so if you were seeing him, he went home a week later. So if you went to do the assessment and you watched this mom feed this baby, you would think, this is atypical feeding for a baby. But to me, as a NICU OT, this feeding is typical. This is how babies, premature babies, need to eat. They have to, mom can't cradle them in her elbow. She has to hold them with her hand so she can feel the breathing, so that she can see the breathing. She's using a little left sideline technique because he had an NG tube for so long that we sideline the babies on the left, not only to prevent the milk from going over the back of the throat too fast, but also to put a little pressure on their lower esophageal sphincter to help keep it closed so he won't have any reflux while he's eating. So this stuff is atypical, but for a premature baby, this is completely typical. This is how we teach them to eat. So the reason that the difference in seeing this baby and another baby is that you need to ask the mom how she feels about this feeding. Is she anxious? Is she responding to his cues accurately? Or is she staring at her phone or the TV instead of him? So listen when I ask her.
All right, so Mom, before we start to give him a bottle.
Let me go to the next one. Here you go.
Today he's 30 days old. So on a scale of 1 to 10, what do you feel is your confidence in your ability to feed him?
Oh gosh,
I know what Daddy's is. He's been feeding him for a while too.
probably a 9 or a 10. I mean, I think it's been a process, but learning what he needs from us in terms of pacing, and then
so you're right. You
what
know
he's
his cues,
learned. Yeah,
you got better about reading his.
Okay, so she feels like her feeding is a 9 or a 10. So that is a typical feeding for her. So it may look atypical to you, but it's typical for the baby. So here's another question for you. Let me know, as an infant approaches 6 months, iron in breast milk may not be nutritionally sufficient. Is it a fact or a myth? We'll take a poll, Jeannie. You can show everybody the poll. Okay, good. So it's about 50-50, 55%, 45%. Good. So about 50-50. So it's a fact. This is a true fact, and it is the takeaway tip for 6 months to 1 year of age. I want you to think about it for a second. Infant formula given to a baby on the first day of life is the exact same combination of ingredients until 12 months of age when a child changes to milk, right? Well, breast milk changes all the time based on the age and needs of the baby. It's like remarkable. Routinely, though, breast milk decreases in the amount of iron around 6 months, which is why breakfast cereals and first puree foods after 6 months should be iron enriched. So sometimes you see the boxes of cereal that we start with at first, Cheerios, Kix, Rice Chex. Those on the box will say iron, vitamin D enriched. You can also start babies on soft tofu if the family doesn't have any allergy to soy. You can try sweet potatoes and egg yolk. Red and brown rice will be good, beans, and some pureed meats, which is why we still see those yucky meats on the shelves at grocery stores. There's usually like veal or turkey or beef, little meats, because you can start those too to help with iron. But be aware, put an asterisk on this somewhere on your paper, that be aware of a mom who tells you that her baby used to be awake, alert during the day, rolling over, the baby loved tummy time, but now at 7 months old is pale, has a poor appetite, sleeps longer at night, and requires more naps during the day. And the doctor is worried because they're not gaining weight. Usually a pediatrician will check a baby's iron around 6 months if they know a mom's breastfeeding, but sometimes you might want to encourage her to talk to her pediatrician. So just an FYI for you, breast milk is also low in protein, vitamin D, and zinc. So this is one of the big reasons why premature babies are discharged home from the hospital on a couple bottles a day of fortified breast milk. So we add baby formula powder to breast milk, and sometimes some babies even need more than that, so they go home on liquid multivitamins or vitamin D, which are then added to the breast milk too. Okay, so next, 6 months to 1 year olds. So refer to your handout for typical expectations and behaviors of this group. So my biggest tip is to inform parents that introduction of pureed or soft solid foods during these months are not for nutritional means. They should just be fun, exploration, building taste, smell, oral motor skills. They should encourage self-feeding and determine intolerances or allergies to different foods. So typical everyday nutrition at this age should still be from breast milk or formula only, around 30 ounces a day, depending, of course, on a caloric or volume requirements of the individual child. I'm always worried when the mom tells me that she gives four-ounce green bean packets twice a day and the baby only drinks 10 ounces or 12 ounces of breast milk a day or formula per day. I'll say, you know, these baby still needs to get about 30 ounces of breast milk or formula a day during this age group, during this age. All right, so what's atypical for this group, this age group? I've given you some ideas on your handout if you want to take a look at them. But take a look at this child. He's 10 months old. He's a former preemie, as you can tell. If you have seen preemies before, you could tell he just has that preemie body and preemie face. He's a 24-week or so. Now he has severe chronic lung disease and he's on oxygen. I don't know if you can see it, but it's on his face. He has a gastrostomy tube on his belly. His mommy has a little pad there around there so it doesn't leak. And he had delayed oral feeding in the hospital because of his chronic lung disease. He has some dysphagia from the ventilator, so he's having trouble swallowing. And of course, these children always have very slow and poor growth. So here he is trying to feed himself using a spoon with one hand, and then he's blocking himself with the other hand. Seeing him during an initial team assessment, you can tell he has a serious feeding problem. He has some serious sensory issues, some motor issues. But after we asked more probing questions during the assessment, we found out that the pulmonary and gastroenterology doctors do not want him wasting any calories eating or drinking or, of course, crying. So at this time, oral feeding is just for fun. So does he need a feeding specialist? No. A developmental specialist or other primary provider, PT or OT, can coach this family through pre-feeding, basic oral motor skills, and decreasing sensory issues during play and meal times while they're there working on his other IFSP goals. So Jessica Hale, the developmental specialist, will explore these with you next month in part 2 of this webinar. Okay, I have another myth or fact for you. So we hear this, I can't tell you how many times. If a child is hungry enough, he will eat. Is that a myth or fact? Thank you, Jeannie. So I have two people, 5% said that it's a fact, and 95% of you said it was a myth. Thank you, Jeannie. Okay. Click on my slide. So actually, it's both. So you are all right. According to the American Academy of Pediatrics, 94 to 96% of children will eat when they are hungry. So that's true. However, 4 to 6% of children, especially ones with medical or developmental disabilities, do not have or interpret hunger and satiety cues correctly. So it's hunger and feeling full. Children who have been tube fed, who have severe environmental neglect or physical abuse, or have had gastroesophageal reflux disease, feel hunger cues as pain or burning, and they cry when they see food. Then parents respond by withholding food because they believe the child doesn't want to eat it. So it's a perpetuating a vicious cycle. So after a certain point, these bodily cues become suppressed, unfortunately, leaving the child little to no feelings of hunger or feeling full at all. This last percentage of children and their families definitely need the help of a feeding specialist, but the other 94 to 96% of children do not. So moving along, now think about 1 to 2-year-olds. You can take a look at your handout. I've given you just some ideas, but there's lots of typical feeding requirements for this age group. I've just listed a couple. So here's another video. She's 15 months old with Down syndrome, and she still eats only chopped, soft, solid food. And as you watch the video, ask yourself, does she need a feeding specialist?
It's a mower. Oh, it's a mower. Mower. Just a mower. Yay! Good job. Oh my gosh, good. It's amazing. You know it's amazing. I know you know. I know you know, but I think it's amazing. Do you want some more? Yay! Oh my God. High five. Good job. Sort of. Yay. High five. Yay. Yeah. Oh my God.
So she's doing so well for her age and her current level of gross and fine motor skills, her problem solving skills, and her oral motor control. So while her family keeps practicing these skills through routine and future learning opportunities, her moms want to start working on language and communication. So eventually, increased self-feeding and transition to soft table food will happen, and it can be coached by primary providers working on her communication goals. So she's another one of my typically atypical children that does not need a feeding specialist. Okay? So I have another one because now we're on atypical feeding for children 1 to 2. So I've listed some atypical feeding behaviors to be on the lookout for, but I'm sure you've all seen so many more. So please watch the next video. This is my friend Iris, and ask yourself if she needs a feeding specialist. So just a quick little background. She's 18 months old. Her grandma is the one feeding her. She drinks broth from the family's daily soup, which she drinks by spoon 3 times a day, in addition to getting 15 ounces of milk a day.
Dĩa tụi vô điên này, vô điên. Nè. Dĩa tụi vô điên này. Chị mà đến nêu quăng.
Okay, so this is atypical, definitely. This is atypical feeding for an 18-month-old. There are so many things happening here that it screams, ask more questions. So when we found out that Iris's grandma is from China. She's her primary care provider. She came specifically from China to assist her mom with raising her and her 2-year-old siblings. So we continued to ask more questions, and we learned that in China, the children are not allowed to feed themselves until the ages of 3 to 5, depending on their dexterity with their utensils and chopsticks, whatever they use. And the reason is due to the Chinese culture of not letting the children be dirty or messy. So that was the reason why she held the napkin under her chin and kept wiping her face, which was driving me crazy, but it didn't seem to bother Iris because she's used to it. So additional questions revealed that Iris gagged and cried, which was typical for a 6-month-old, but she started vomiting to get her way and not eat the foods at 6 months that the family was trying to give her. Even when they tried pureed foods and puffs and soft table food, she did the same thing. So the family just stopped giving her these foods, and they stayed with broth. They knew that she needed to work on her spoon feeding skills, but they didn't know how to advance the texture. So we call this a stall. or a food jag. Sometimes you'll hear it, they'll say a child stalled, or there's a food jag. And it's when a child is in the process of learning a new skill, the parent's response triggered a maladaptive behavior and avoidance by the child to direct attention away from their difficulties or their challenges. So the parent is afraid or anxious to push or encourage the child, so the child stalls. Iris has an awesomely great support system. So she doesn't need a feeding specialist per se, but she does need a coach who can restart her at a 6-month-old level through caregiver education, mealtime routines, and increasing safe and supportive learning opportunities. So remember, I want her, as an OT, I want Iris to do more for herself, but culturally, this is not appropriate. Work with the family to understand how you can help their child through their eyes. Learning about different cultures and cultural differences can be fascinating. Embrace it. You might even learn a few new things yourself, which I did. So how many times have you heard this when evaluating or seeing a toddler? Usually it's from a first-time parent. They'll say, well, I'll say, have you advanced to soft solid food? And they say, no, I haven't done that. My child doesn't have any teeth or only 2 front teeth. So they delay offering a child soft solid food and vegetables, cereals, soft meat, because their child only has 2 front teeth. So assure parents that a child does not chew with their 2 little front teeth. A child needs to practice chewing soft foods on their gums where their molars will eventually be. So take a look at Levi. This is my next video. His parents are eating a taco, so they let him try it.
Taco. They're yummy. Right? Wow.
So as you can see, most of the food ended up back on the tray or down into his bib, right? But he had a great learning opportunity, biting off pieces, munching and chewing on both sides of his gums. He tried a little self-feeding, and he was interacting with his mom and his dad, who was holding the camera. So in this age group, we hear this often too. But if a family uses and eats meals with a certain spice or flavor, whether it's culturally or naturally, it's important that the child is exposed to these early when they're beginning to eat a variety of foods, because in the long run, they'll be less picky about foods as young adults. And I encourage moms to start adding old world spices in their first puree foods, even sprinkling it on baby food if they have it, like cinnamon. That's always a good one to start with. Nutmeg, ginger, garlic, dill, and rosemary. Those are nice, easy ones that you can add to start spicing up a child's diet towards what the family usually puts in their own food. So as an FYI, and not currently in this pandemic, but as an OT and as a wife of a gastroenterologist, I will tell you that I encourage a little dirt, a little mulch, floor scraps, sharing of family foods, and definitely picking and eating fruits and vegetables from the garden at this age too, because a child's developing a microbiome, and good bacteria is necessary for a healthy gut. I always gross out Stephanie and Jessica or the families when I tell them that I grew up on a farm and the best thing to do on a summer day was take a good long drink from the hose. They think that is the most disgusting thing they ever heard. But to us as kids, we thought it was great. So typically for 2 to 3-year-olds, they are the most difficult of any age group for sure. So take a look at my handout and see if I hit a few things that you've seen. This age group wants to do everything themselves. They're desperate to get your attention and to be under parents and other siblings' feet. They tell parents, so you can tell parents that they're messy, they're scared of new foods or the different look of old foods that they used to like. We call that neophobia. And they want to help cook, set the table, pick what and how much they eat, like in a buffet type style dinner or lunch. And so I want to show you, this is my friend Giovanni on the right. And he's having, on his head, he's having a 24-hour EEG to check to see if he's having any seizure activity. But he has a severe developmental disability, but I was always so proud of his parents for involving him in different learning opportunities to help him pay attention and decrease his sensory issues. And then, of course, interacting with his dad, who's holding the bowl for him.
Okay, that's enough. Crack it.
Go ahead.
Now break it.
Crack it over the bowl. Oh, good job, G. All right.
He always cracks me up when I look at that. He always has that surprised look on his face, like, I did that? Wow. But his dad was so good, wasn't he? All right, so let's place a stamp on this one. If a child rejects food, he doesn't like it. What do you think? Is it a myth or fact? I think I wanted you to give a stamp this time. There you go. We hear this one a lot. That's why I know you've probably heard this before. True. Thank you, everybody. That is such a myth. That's like one of the biggest myths ever. But parents will tell you, no, he used to eat broccoli, but now he doesn't eat broccoli anymore, so he doesn't like it. No, it's not true that he doesn't like it. So in this age group, the takeaway tip is big. I want you to know that this is big. Remind anxious or worried parents that between the ages of 2 to 3, growth slows down. Infants triple their body weight and toddlers increase in height, but the growth of a child between 2 to 3 slows down. Children don't need the calories or the volume of food or liquids that they used to eat and drink. That's why they're picky. If you weren't very hungry for lunch because you ate a really good breakfast, then grabbed a handful of goldfish for a snack an hour before lunch, wouldn't you only eat the food that was on your plate that tasted the best? I would. So imagine for a minute. So a parent puts a peanut butter and jelly sandwich, 3 carrot sticks, and 5 chips on the plate for lunch, okay? If the child's not that hungry, won't he just eat the chips? Usually. So if a mom responds by thinking her child doesn't like carrots and peanut butter and jelly anymore, she offers chips the next time because she thinks the child likes them. But if you tell her, or she's aware of what her child's already eaten that day, and she decreases the portion sizes with maybe 1 or 2 carrot sticks, half of a peanut butter and jelly sandwich, but she adds maybe a dollop of ranch dressing for dipping, and she avoids the chips, she might be surprised at the outcome. It may only be 1 bite of sandwich and dipping 1 carrot in the dressing, but it was better than eating just the chips, right? So parents sometimes just need basic education of meal choices and volumes and amounts and when and how much milk to offer, during or after the meal. So I like myplate.gov, myplate.gov from the government, and I usually give the parents that website so that gives them a guide of how much their child should eat. So You never thought about adding spices for food for toddlers? I'm just reading the chat now. It makes sense, but you never considered it. Yeah, babies love spice. Sometimes they won't eat some of that baby food because it tastes like nothing or it tastes gross. So, and I didn't with my babies either, Corey said, but yeah, definitely add some spice to their life. That might even get these picky toddlers, if you give them a smaller meal and add a little spice to it, they might like that. Plus, the other thing about 2-year-olds is they need to see food several times before they'll touch it, a new food. So more times, they need more time before they'll take a bite, and sometimes even a longer time before they'll start to eat it without a fight. So my best strategy to tell parents is when you're trying a new food with the family for dinner, put the new food on the parent's plate or on the other sibling's plate and see if the child will ask for a lick or for a bite. And there's no bribing or punishing this age group if the child refuses. You say, okay, if you don't want it, you just need to eat what's on your plate. It's no problem. All right, so let me get to the next one. Okay, here is atypical issues for 2 to 3-year-olds. I wrote some things for you, but I know that I only touched on my handout what you've probably seen. But this is my friend Declan. He's 33 months old, so take a look at his video. He's just about to transition to school from early intervention, and you will see that he has a severe developmental disability too, which requires a gastrostomy tube for all of his daily nutrition.
Grant, what you doing? And that's fun for you, right? That's fun.
So he's trying so hard, isn't he? Definitely atypical behaviors for a 33-month-old child. But his mom provided an excellent learning opportunity to let him feed himself, get messy, and above all, he enjoyed it. He's not crying through it. He's picking it up. If it falls down, he just picks up another one. So does he need a feeding specialist? No. He needs more practice and more learning opportunities and time. So we're coming to an end of the webinar. I'm just looking at my time clock. And I've given you a lot of information, and so much information that that's why I wanted you to have a handout so you can take a look at it afterwards. But I've tried to give you the education and the tools to coach families through typical and atypical feeding issues for children birth to 3. So I've also showed you various examples of children with atypical feeding behaviors that did not need a feeding specialist. So if you feel you can start helping families, I encourage you to try, because feeding and doing feeding therapy can be a lot of fun. Because some families, mommies especially, at times are so desperate for help or reassurance that they'll do anything that you suggest. But be forewarned, if you don't feel comfortable or you've reached a place where you need guidance or help with a technique or next step, back away, because no feeding therapy is better than bad feeding therapy. Ask for a consult with a provider in your system that has experience with these issues, because unlike trying to get a child to roll or to stand and to walk or to talk, in some of these cases, you can actually inflict or induce harm or pain, constipation, diarrhea, vomiting, bloody stools, and so much more, that if you don't understand these child's issues could have ramifications for that child. So please be careful. So what else is out there for feeding therapy? And what else can you do for a next step? So especially if you are the primary provider, there are other alternatives. There's outpatient therapy, and then there are inpatient therapy feeding programs. So put a stamp for me if you've ever shared a patient with an outpatient therapist at the same time. So you might have been doing OT, yeah, but they were going to the speech therapist as an outpatient, or you were the PT and they were getting OT as an outpatient therapy. Or if you saw a patient after they came home from an inpatient feeding program. Cool. So you guys have done that. Excellent. So it's definitely appropriate to guide and coach a family to take what they learned in the clinic or in the hospital during their stay and apply it to their everyday mealtime routines, because sometimes children will do things in the clinic or at the hospital that then the moms can't figure out how to get them to do it at home. So gently encourage parents to expand the child's learning opportunities to the rest of the family's routines and in various natural environments like daycare. Sometimes they'll get the ideas of what to do from the therapists and from the feeding program at home, but then they go to daycare or grandma's or church or even sitting on a blanket at one of their other siblings' soccer practice. So sometimes parents need you to give them that bridge of what they can do, how they can take what they've learned and then use it at home. So remember, these are family-led feeding outcomes. They're not just individual therapy goals. So this is my friend Mara. Remember her from the earlier slide with her dad eating on the couch? So mom really wanted her to eat one meal a day at the table instead of on the couch as a family without TV or an iPad. And she wanted it to be achieved by the time dad came home from deployment. And as you can see from the bottom picture, that we're happy to tell you that that goal was achieved, because a happy family is a therapist's biggest achievement. To me, seeing that picture at the bottom is the biggest achievement for me. And hopefully you realize today that it doesn't always need a feeding specialist. Okay. So here's my picture from the beginning. Part 2 will be with Stephanie, our service coordinator, and Jessica, the developmental specialist. And Stephanie will help you understand the important role of the service coordinator in exploring and gathering and compiling of all feeding concerns and routines and abilities from the family and guiding them through their early intervention experience. And Jessica will help you delve further into ways in which the developmental specialist or the primary service provider can work on this journey with families. And how can they help families with children with feeding issues? Well, you'll have to come back and join us for part 2, talk on Tuesday next month. So I want you to please stay healthy for your families and for us to get out of this horrible pandemic that we're in. But thank you very much.
Kim, I want to thank you so much for sharing your expertise. If you all have questions for Kim, feel free to put those in chat. Kim, there's some really nice comments coming in, but I did see that Brenda Denny said she strongly suggests spice for G-tube kids. They are so accustomed to sweet flavors coming off of the formula, and
Correct.
you have to surpass that.
That is correct. Absolutely. Thank you very much.
Yeah. As a reminder, if because you already registered for today, you are automatically registered for the May Talks on Tuesday, you will get the login information and any handouts just like you did for today's as we get closer to May 5th. So again, I want to thank everybody and hope you will plan to join us in May. I also you will see that Lisa Terry has just posted in chat. If you are interested in any of the Virginia Early Intervention Professional Development Team's social media, we have Facebook, Twitter, YouTube, Instagram. It's all there, and you are welcome to join us. So again, thank you to everybody, and I second Kim's comment, stay safe and stay well. Thanks, everybody. Have a great afternoon.